Hi everyone, I'm Dr. Ashley Ross. This is Dr. Hiten Patel. We're both faculty here at the Northwestern Feinberg School of Medicine in the Urology department. This is Prostate Cancer Awareness Month, and so for this segment we wanted to talk a little bit about some frequently asked questions and sort of give answers to those questions. Both Dr. Patel and I are specialists in prostate cancer, and we're really glad that you came to this video. Yes, so there was Dr. Don Gleason was a pathologist who years ago, when he was looking at prostate cancer, was trying to categorize among the adenocarcinoma, which is by far the most common type of routine prostate cancer found. Can we put it into different buckets of how aggressive it looks under the microscope? And he came up with a Gleason rating system that went from least aggressive to most aggressive. That's been modulated over time. Most of us now use Gleason grade groups when we talk to our patients. These groups go from 1 to 5. 1 is the least aggressive group, 5 is the most aggressive group. We sometimes will still talk about the old Gleason sums as well at the same time, because some patients, or if you look on the internet, you might be used to that. The low grade cancers would be Gleason 3 plus 3 equals 6. But then the highest grade cancers would be sums that equal 9 or 10. The reason we went to the Gleason grade groups, in my opinion, or one of the reasons was, like we were mentioning earlier, a lot of prostate cancers that are low grade, particularly if they have lower PSAs, lower amounts of tumor in the prostate, we were following those men. And sometimes if you tell a gentleman that we're going to follow your cancer, it's the lowest grade is 3 plus 3 equals 6. That sounds like you're halfway to 10, or more than halfway to 10. So it's better sometimes to communicate that that's Gleason grade group 1. But it's basically a marker of aggressiveness of the cancer as visualized by the pathologist under the microscope.
So I think one study at Northwestern by some of our other faculty colleagues randomized men to saying, well, what terminology do you like, or what makes you more anxious? And the terminology for grade group just happened to be the one that made the most sense and most reasoning. And so doing a 1, 2, 3, 4, 5 is our 5-point scale makes sense, and it represents the aggressiveness of the cancer, and it changes what management option we potentially recommend. Whether it's active surveillance with observation or intervention. Yeah, so changing your diet won't cure prostate cancer. As Dr. Ross mentioned, there are several associations with potential prevention of prostate cancer. Once you've been diagnosed, there are also potential benefits of having healthy diet and physical activity on outcomes. Some for men who are on active surveillance. And again, some of these are general health outcomes, but also potential impact on prostate cancer changes on surveillance. We haven't had huge studies to be able to verify some of these findings, but in general, you can't cure it, but it can help you live a healthier life and potentially a better life in general.
Yeah, I completely agree. Some of my patients will ask me in regards to diet, they'll say, well, so I'm going to cut out all sugars. And my feeling is that can be good, particularly simple carbohydrates are not great for you. But the reality is that prostate cancer to me seems less driven by sugars than maybe like lipids and saturated fats. And so, having a lean body weight is helpful. Prostate cancer is the second most common cause of cancer death among men, but cardiovascular disease, I think, still wins out as the main cause of death. And some of the treatments that we use for prostate cancer, like we're alluding to, can affect your cardiovascular health too. So the more you can optimize your overall fitness, the better. As an anecdote, I have had some patients on surveillance with lower risk prostate cancer who are morbidly obese, so extremely overweight, that have had dramatic changes in their diet. And I have seen on their surveillance biopsies less cancer on follow-up. Not none, not a complete remission, but less. And I've always wondered what that means. And like you mentioned, there are ongoing studies to see if some of the dietary changes or even supplements that can reduce the amount of free radicals in the prostate, those are carcinogen-causing species, might be able to actually benefit these guys. And we're not looking at cures, but you'll live longer.
Yeah, and we had done a review on this, a review article looking at the literature, and it all looks favorable. They're smaller studies, but I think there's something there. But I wouldn't think of it as a cure. But like you said, in terms of response to treatment, being ready for androgen deprivation therapy, all of those things you're optimized, and will, maybe not from the prostate cancer disease course, but your overall life course will be able to extend your life.
mean, I'll be curious to see your thoughts. I think it's a convoluted, parsing. I think that there's, one is black men are not a homogeneous group. They're not all the same, genetically. There are some genetic predispositions out there, just like the Scandinavian population might have a HOXP13 mutation that makes them more predisposed. There's a similar mutation in some Caribbean populations that can do that. There's a lot of issues around screening and things like this, and I've never, I'd love to get your thoughts. I've never been able to parse out, have they adequately controlled for all the metrics around who's getting screening, who's getting access to healthcare, what's the hesitancy to do screening. And so my bottom line is that, African American men might be at higher risk, maybe as high as twofold risk, and they certainly should be getting screened at an appropriate age. I think a first PSA no later than 45, just to see what their baseline is my practice. But I'm really curious to see your thoughts.
Yeah, I think for African American men, the rate is definitely higher when we look at just who's diagnosed and how often black men are diagnosed versus other races. But the question is, well, is that a true association? I think when you look at some populations like the Veterans Affairs sample, and there's one study that showed that in a system where potentially people have a little bit more equal access to healthcare, the rates of diagnosis are definitely, and mortality at least for sure, are more equivalent than you might see in the general population. So I think that says a lot of it is some of it is a health disparity in access to appropriate diagnosis, screening, and treatment. But like you said, there are definitely some mutations in some, especially those who have family history of having had prostate cancer. That seems a little bit more common in African Americans, but it's hard to control for all those factors. And so, I think earlier kind of screening is very reasonable, setting a baseline, and then definitely for men who have a family history of having needed treatment for prostate cancer. Yeah, so I think, again, I'll say for the overall short answer for sex life, if you had good sexual function before diagnosis, it can depend on what your treatment is and what grade of cancer you're diagnosed with. In general, it won't end your sex life. But especially for men who are potentially undergoing surgery or surgical candidates, we can perform nerve-sparing surgeries where you can preserve the neurovascular bundle, which contributes to erections. And so after surgery, even if you had a nerve-sparing surgery, your erections aren't potentially back to what they were right away, but over the first year after surgery, you can recover a lot of function. And most men with the use of adjuncts like Viagra or just other PDE5 inhibitors or treatments, we can get them back to a very healthy sex life. If you have a more invasive cancer or can't have a nerve-sparing surgery, then natural erections are going to be much more difficult. But we, as urologists in our sexual medicine team, have other treatments that we can do to, therapies as well as potentially surgery if you need it, to help men get back to a healthy sex life.
And I would echo that. I think that, for the men undergoing surgery for incontinence, which is leakage of urine, that's a weeks to months process for recovery, and it's almost in all cases complete, particularly for men that are under 70. I would say, complete recovery should be expected in like over 95, maybe even 98% of patients. Sexual recovery, as you said, it's important for the patients to realize their sex life isn't over because sensation to the penis, libido, ability to orgasm, even though no fluid will come out, that is not affected at all. And it's really the firmness of your erection. Now, as opposed to continence, the process that, just like you said, Dr. Patel, it's not a weeks to months process. It's more of a months to years process, and it's more gradual. But there's lots of ways that either naturally and also medically you can get a firm erection if your recovery is going slower, or maybe if you start at a lower baseline, or as you mentioned, if your disease was more aggressive and it necessitated removal of some of those neurovascular bundles. There's multiple methods, and actually at Northwestern, I think it has nationally the most premier men's health department, and we have, just like we have people that specialize in cancer like you and I do, we have a huge cohort of faculty that specialize in how do we get that firm erection and keep the there was one of our faculty, Dr. Morris Sakari, said like, how do we make sure that we keep not just the warmth but the heat in the relationship, and that's a great statement, and I think that many of us do that. Yeah, I mean, I think it's a misnomer, in my opinion, that it's like a slow-growing cancer. The reality is that prostate cancer has a disease spectrum. We talked about Gleason grading before. lots of men are diagnosed with prostate cancer if you screen everybody, and there are a cohort of them that have slow-growing, low-risk cancers that, if advised by your physician and they're an expert, you should be comfortable watching them and not worrying about them. But again, as we mentioned earlier, it's the second leading cause of male cancer death, and there are men with higher Gleason grades, higher PSAs, that do have cancers that cause big problems to their, not only their quality but their length of life. So it should be very forward in our minds, and I think that we have to recognize that there is a large cohort that's of lethal disease out there. So I guess the answer in my thought is like it depends. I think that screening nowadays, particularly here, and I know in your practice and in mine, as you kind of outlined before, it's a tiered process. We're not taking everyone to biopsy. We're really being very careful about how invasive we're being during screening, and we're trying to only treat cancers that we think are going to cause problems for men and watch all the ones that we don't. And so with that in the background, I think that men should be very forward about undergoing screening, and I think that we'll hopefully see some of the guideline bodies really try to promote this and maybe change their course as they realize what we're doing. But I would say for all the men out there, have strong consideration for thoughtful prostate cancer screening and treatment when appropriate.
Yeah, no, I agree 100%. So we really want to find those cancers that do need management, do need intervention, or at least a closer follow-up. And we try not to find as many of the low-grade cancers we know aren't going to impact a man's life in the next 10, 15 years. If we do find them, observation or active surveillance, depending on what your urologist recommends, I think shouldn't cause anxiety. I think that's an appropriate recommendation and often in the patient's best interest. And so, for those cases, I wouldn't worry. But in terms of if you have a high PSA, if you need screening, I think getting the appropriate diagnostics and not putting it off because you said, well, even if my PSA is this high, or I have these symptoms, I shouldn't get checked out because it's not something to worry about. I think it's still something that you need some care for and to be seen for, but you can get a lot of reassurance if you had a low-grade cancer from your urologist.
Well, as we were sort of mentioning, there was a lot of back and forth from some of the guideline bodies. I think that added a tremendous amount of confusion to a lot of the general practice physicians, and because of that, some of them have said like, well, maybe we just shouldn't do prostate cancer screening. One thing that I would encourage if your GP, won't give you a PSA screening test is to first have like maybe a slightly more thorough discussion with them, and just say, well, why exactly, and what's the literature, what's the literature around it, and if you wanted to bring in studies, you could say, well, the best performed studies were the European randomized prostate cancer screening trials, and look, there's a mortality benefit from prostate cancer if we do early screening. A lot of times, if you have just a very mild amount, I don't want to call it pushback, but maybe shared decision making, then they say, yeah, that makes sense, let's do the screening. The second thing you can do is that sometimes we'll see patients, I've seen them in my clinic at least, come in to see me as a urologist, and they come to see me for their general urology health. They want me to initiate the prostate cancer screening. It's more rare. Usually the screening is happening in the GP, but they just say, look, my GP's not comfortable. They don't understand how to handle all the numbers that are involved. There's no cut point per se that is well defined. So I want you as a urologist to do my screening, and that happens not infrequently. I see maybe a dozen or two patients a year like that, and we initiate screening together. So there's always an option for you, but I think that sometimes having a frank discussion, makes sense. So, for example, if you're an 84-year-old and your GP will not do PSA testing, and you say, well, why? And they say, well, there's no benefit in that population, and you had a PSA a few years ago that was under 3. No one dies of prostate cancer in their 80s when their PSA has been under 3. So we're not going to do PSA screening. You may stop. If you're a 50-year-old who has had 3 brothers who've had prostate cancer, who's asking your GP for a PSA test because you're really worried about your prostate cancer risk, and the GP says no, then a more of a discussion coming in to see a urologist on your own accord. If you're still getting pushback, I think makes sense. So it's a spectrum.
Yeah, I agree. I think if you're definitely in the 55 to 70 range, and are generally healthy, I think having that discussion is definitely appropriate. If you're younger or older, still reasonable to bring up and talk about. I would say that there's maybe a good reason your GP is not recommending it. Like you said, you might be in a situation where screening may not be ideal for you. Maybe the cost benefits are favor not having it. And so there's reasons. So I think just bringing it up, talking about it a little bit more, and then a urology referral just for especially if you had any urinary symptoms or anything else anyway. That's a reasonable place to also increase the discussion if they're going more on just the general guidelines or may not feel as up to date on it to be able to discuss it. So we're always happy to do that with the urologist for sure.
Yeah, and now I think that all the guideline bodies now have moved towards shared decision making for the at-risk population around PSA screening, and like I said, I think we're going to see that's PSA-based prostate cancer screening. And I think we're going to see even more kind of expansion of that, because I just think that the way we screen for prostate now, there's more tools, it's more thoughtful. Obviously, there still needs more initiatives kind of coming forth to think about things at a population level with cost and benefit. But for you as the patient, I think what I've learned in the last decade, as we saw those guidelines change around, as we saw some guidelines for the general medicine practitioners to not screen, and then a rise in metastatic rates, and then maybe shared decision making, I would say you should have a renewed vigor when you think about your health for, as we talked about today, managing your cancer risks. So, thinking strongly about prostate cancer screening, because it's the most common non-skin cancer in men. Same thing about thinking as we think about colorectal cancer screening. We talked about cardiovascular health. These are major things that you can do to just make sure that you're on this earth for a long time and have a good quality of life.